Good afternoon, everyone. Thank you so much for joining us today. I'm a consultant from the Cactus Regional Consulting Group. My name is Twee, and today with me here are Tiffany Chin, Brittany Seidemann, and Ryan Thomas. Next slide, please. Thank you. We're here to present to the board our solution on whether or not NorCal Health System should expand into the Inland Empire. Some assumptions we gathered before analysis were it is a nonprofit organization primarily focused to serve Medi-Cal and Medicare enrollees, which is a similar structure to Loma Linda University. But it does have a 3-year time frame to break even and eventually make profit within 5. Next slide. The Inland Empire is a 2-county region split between Riverside and San Bernardino County. And between these 2 counties is a population about 4.5 million people. The population growth in Inland Empire has grown at a rapid rate than the statewide average, with the region growing at 5.5% over the last 5 years and 12.7% over the past decade. And their Latin population continues to flourish and now accounts for just over half of the population there. Next slide. So with Riverside and San Bernardino being the 5th and 6th largest counties in California, respectively, some of these county facts stood out to us, such as the rate of those who are uninsured over the age of 65 in both counties are over 9%. And there are over 200,000 veterans in the Inland Empire. Furthermore, the annual household incomes in Riverside and San Bernardino are consistent with the poverty rates displayed, with San Bernardino having a higher poverty rate and lower income than Riverside. These findings reflect a greater need for healthcare support and services to boost the residents, communities, and extend their well-being. Next slide, please.
After exploring the demographics, we wanted to further look into the health insurance trends and what residents report as their main coverage source in the Inland Empire. The data shown in the table here was collected from a region market report that the California Healthcare Foundation released last year. And as we can see here, Medi-Cal and private insurance dominate the region, with 33% reporting Medi-Cal and 43.5% reporting private insurance in 2019. We can also see that Medi-Cal has almost a 4% higher rate of residents reporting it as their main coverage source when compared to state level data. Next slide. Now, since Medi-Cal has such a large percentage of enrollees in the Inland Empire, we wanted to see the difference in enrollment between Medi-Cal and Medicare. So as we can see, based on county population size and total eligibles that were collected from CMS enrollment reports, we were able to calculate how much of the population were enrolled in either Medi-Cal or Medicare. And we were also able to see that from 2019 data that was presented on the previous slide, there was an increase in enrollment from 2019 to 2020 in both Medi-Cal and Medicare. Next slide.
Thank you, Brittany. So this map shows prominent ownership types found within cities in Riverside and San Bernardino counties, or cities, sorry. Counties. It helped us examine the financial trends within the Inland Empire and helped in our market analysis. For-profit hospitals show some of the largest net from operations here. Large nonprofit hospitals have some of the lowest total margins and lowest nets from operations in the 4th quarter of 2020, according to data from OSHPD. Next slide, please. I'd like to talk a little bit more about some trends in the market. The number of FQHCs and patient visits continues to grow, helping the safety net. FQHC patient visits have doubled from just under 500,000 in 2014 to more than 1.2 million in 2018. Many physicians practiced independently in solo or small practices. And the region's hospital market remains very unconsolidated. And it should be noted that San Bernardino and Riverside counties have among the lowest levels of hospital market concentration in California. The Inland Empire Health Plan, Pay per Performance Initiative, incentivizes providers to meet specific measures aimed at delivering quality healthcare to Medi-Cal beneficiaries. There is a lack of data sharing within the region, and the region continues to struggle with recruiting primary care clinicians and specialists. Next slide, please.
Now, before we talk about the key stakeholders, we first want to address the mission, vision, and values of NorCal Health System to provide an overview of what they stand for. We assume that the organization's vision closely aligns to Loma Linda universities and other academic medical centers, as well as community hospitals and regional health plans. That is to enhance community well-being and the social determinants of health to achieve the triple aim, which is through better health equity, affordability, and accessibility in compliance with the Medi-Cal 2020 waiver. Next slide, please.
Now on to our stakeholders. We've identified 5 primary stakeholders who align with our mission, vision, and values. Loma Linda University Health System is a nonprofit organization with 6 hospitals in the area involving general acute and specialty care, and hosts a competitive teaching hospital program. They account for around 13% of all discharges in the Inland Empire and are known to be a safety net provider helping many Medicaid and uninsured populations. Our UHS is a public government organization composed of teaching hospitals, 12 FQHCs, and a 439-bed medical center. And they have 95,000 IHP Medi-Cal beneficiaries enrolled into their healthcare system. Western University Medical Center is another nonprofit organization primarily serving in Pomona and Rancho Cucamonga. They have services in 6 specialty areas and are known for their comprehensive care and teaching hospital status. SAC Health System is also a nonprofit organization and is the largest federally qualified health center in the region. They see over 144,000 visits each day among their 7 locations and have a 3-clinic system in San Bernardino. And lastly, IHP is a public insurance plan accounting for about 25% of the Inland Empire's population and is the largest Medi-Cal managed care plan in the region. They have over 1.3 million members, over 6,000 providers, and over 2,000 team members working at their organization and strive for continuous quality improvement for the incentive programs they offer their beneficiaries.
So to evaluate the likelihood for success, we will look at NorCal Health System's critical success factors, or CSFs. There are 3 short-term and 3 long-term CSFs, totaling 6 main factors. But today we'll focus on the top 3 in the short-term portion. Although potentially receiving patient referrals and affiliating with safety net hospitals with the respective stakeholders, the issue lies in successfully enrolling the minimum number of 200,000 Medi-Cal enrollees within that time period. After projecting a significant push for about 35% enrollment of Medi-Cal patients and 15% of Medicare beneficiaries, it is a tall order with visible gaps to close as seen in the following timeline. Next slide, please. So this timeline shows that the initial marks at the beginning of the project is essential to set the premise for NorCal Health System's presence and to meet their objectives. However, even with consistent efforts of enrolling with a healthy projected estimate of 50,000 individuals per fiscal year, the timeline to achieve enrolling 200,000 members at that benchmark cannot be met within the 36-month period. There are still other obstacles that NorCal Health System will need to overcome. Next slide, please.
Now, to continue to determine if expanding into the Inland Empire is feasible, we wanted to consider our assumptions that we stated earlier and the resources we had and analyze them through the SWOT analysis. Looking at our strengths and weaknesses, a major strength is that we have the potential to reach a high volume of Medi-Cal beneficiaries due to Medicaid being a growing presence in the Inland Empire. And a great opportunity is to continue our partnership with Loma Linda University Health System, as well as expanding to partner with other teaching institutions. When looking at weaknesses and threats though, we have a few weaknesses where there's a limited time frame of 3 years to break even, which may not be feasible. And another weakness is that there's fewer than 5% of residents living within a half mile of a major transit stop. And when looking at threats, we have determined that Kaiser Permanente has a very large presence, and due to that large presence, they may be a potential competitor. Next slide. With Kaiser having such a large presence in the Inland Empire, we wanted to further look into what they consist of and what they contribute. So Kaiser is a nonprofit that expanded into the Inland Empire in 2011. They operate an integrated delivery system. They have 4 hospitals. They have their own network of providers, and they have about a quarter of the regional market in terms of covered patients. And when looking at the slide here, we can also see that Kaiser provides coverage for 110,000 Medi-Cal members, and they also have a subcontract with the Inland Empire Health Plan. We can also see that Kaiser just recently opened up their own medical school in Pasadena, which gives them a constant flow of physicians going into their facilities. This gives them a huge advantage over other hospitals in the region who are trying to compete and recruit for new physicians. Next slide.
So we decided to work inside Porter's 5 forces framework to really examine factors that impact the business environment in the Inland Empire. This service areas analysis is utilized by the Harvard Business School, and we were able to identify these 5 forces that make up the competitive environment in the Inland Empire. 3 of the 5 forces we found were unfavorable for moving there. That is threat of new entrants, bargaining power of suppliers, and bargaining power of buyers. This ultimately helped Cactus Regional Consultants answer the question, should NorCal Health expand into the Inland Empire? Our recommendation to the board is no. Next slide, please.
Thank you, Ryan. As previously discussed, the shortage of providers is prevalent in the Inland Empire. Even taking cost-effective measures with employment, such as hiring advanced practice clinicians for primary care services, and as well as community health workers and health coaches to manage the follow-ups, there will be still a major imbalance of the provider to patient ratio. Thus, the strategy to penetrate into Inland Empire would not be viable or advised. Next slide, please.
So before we get started on this slide, I do want to apologize for the typo under the gross profit margin column. The numbers should be formatted as currency and not percentages. But back to the case analysis. Since NorCal Health System's mission and organizational structure is similar to Loma Linda's, we looked at trends in Loma Linda's revenue and expenses to base our profit and loss statement off of. We estimate that NHS would generate approximately $558 million of revenue within the first year, but have approximately $2.9 billion in expenses in that year as well. Assuming that NHS continues to enroll a steady amount of new patients each year, we estimate that the company will not break even until fiscal year 6. And besides not being able to break even within the 3-year timeframe as a reason to why NHS should not expand into the Inland Empire, the unchanging market in the region suggests that there just aren't enough Medi-Cal and Medicare beneficiaries in the region for the company to enroll into their health system, especially with Kaiser being such a dominant force in the market. In addition, even a large healthcare organization like Kaiser, who expanded into the Inland Empire in 2011, only managed to enroll 110,000 Medi-Cal beneficiaries into their program. All of this, along with the low percentage of primary and specialty care providers in the area, indicate an unfavorable strategy to expand into the Inland Empire when analyzed by Porter's 5 forces. And this does conclude our presentation. Please check the information we have in our appendices for further details. Thank you, and do you have any questions?
Hi, this is Victor. I have I know we have limited time, so I'm not going to ask all my questions, but I do have one specific question. In reviewing your data, I'm curious about whether you reviewed any of the Medi-Cal lives or Medicare lives in that entire region. What percentage of that was capitated? And if of that, or maybe you may not know this, or perhaps estimate what hospital system that was capitated to, whether it was the clinics or whether it was just IHP directly, or were there any IPAs involved in any of that capitation or in that capitation model? And just curious to see if that went into your Porter's model of decision making.
Victor, that's a good question. Yeah, I will answer that question. So in regards to us calculating for the capitated services, I think we were able to do the analysis towards the beginning. And given for the IPA networks with the physicians and such, looking into the almanac from the California Healthcare Foundation, it did look like they, and based on the Inland Empire region, it did look like they were more focused on having more of like the smaller practices and the clinics on that, even when these physicians are residents or student physicians at this point. So with taking that into account, with the Porter's 5 forces framework, it did look like that aspect of it, that channel of the suppliers was still limited.
Demetrius here. One more question, because I know we are short on time, but it seems like through your analysis, I hope I don't misspeak, you can correct me if I did, part of your recommendation involves Kaiser and the number of lives they've been able to acquire in Medi-Cal. How did you come to the conclusion that that was a focus of what the market they were trying to grow? And if they were?
Right. So we actually were wondering the same thing, and we were wondering how can, if we were trying to offer other services in the area, because we consider telehealth, home health, what would make us stand out and differentiate us from our competitors? And so we looked into various organizations. For Kaiser in particular, we wanted to figure out what services they weren't as strong as, and potentially work harder in that service area to gain more beneficiaries to enroll into our program. And one of those was behavioral health. So we looked into Kaiser's strategic plan for the upcoming years, 2021 and beyond, and they do have a community health plan set in motion, partnered with Loma Linda and other organizations in the area to focus on Medi-Cal and vulnerable populations in the Inland Empire, and expand upon their behavioral health, primary care services like that. So there was an indication that they were trying to bring in more Medi-Cal vulnerable populations into their network.
I have one more question if we have time. I'm wondering to what degree you as a group dug into the array of large and or well-established medical provider groups that are either working independent of health systems and or that are aligned with some of the other health systems as a potential partner as you establish kind of this network that would be kind of your front door, if you will, associated with managing prospectively this kind of Medi-Cal population in unique and or different ways. So to what degree did you explore some of those provider groups as potential partners, as an entry point and or a way in which you might pursue this business in this market?
So I think we didn't expand upon that area probably as much as we did the academic or teaching hospitals that we were focusing on, just because in our initial analysis, one of the main goals was to see where we could be different. And one of those was to provide either a home or base clinic and do more telehealth and home health, and to have the residents or med students who are in those academic institutions go to those clinics to receive clinical hours. But then they would also, since they already have their own academic institution, there need to be other incentives for them to come to our clinic. So we mainly focused on the bigger institutions and we didn't dive as deep into the smaller provider networks.
But at the same time, we did recognize that smaller clinics, well, as smaller clinics, physicians usually have a larger ratio of patients that they're already seeing. And we don't want to overwhelm that system as well by having them partner with us and taking on new beneficiaries new patients that they're seeing. So we try to look more into larger organizations as a way to find those physicians who can work for our health system.
Thank you, everyone. The judges are going